Good afternoon, everybody. Welcome to the second day of Virtually Casper. I hope that you've been enjoying the conference so far. I know that I certainly have been. And I have to tell you that this session is one that I've been eagerly anticipating because I hope that it will challenge us to think a bit more broadly and more deeply about the impacts of COVID-19. So it's my distinct pleasure to welcome you here this afternoon to this panel discussion. The title for our session is Collateral Damage, the Unintended Consequences of COVID-19. So I want to begin our time together by just taking a moment to acknowledge that we're on Indigenous lands. We recognize that an acknowledgement of the land is only a beginning. Today we pay our respects and want to express our gratitude to the First Nations and Métis people who are the traditional guardians of this land. Today we reaffirm our relationship with one another. We need to respect the treaties that were made on these territories, acknowledge the harms and mistakes of the past, recognize the ongoing present-day colonial violence that is faced by Indigenous people within healthcare, education, justice, child welfare, and government systems. And we dedicate ourselves to moving forward in partnership in the spirit of reconciliation and collaboration. I'd like to start by thanking our sponsor for this session, CIHR's Institute of Health Services and Policy Research. And before we get going, you may have mistakenly thought that since this is a virtual conference, you'd avoid all those housekeeping rules that normally happen at a conference. But I'm sorry to have to tell you that you are going to have to bear with me for a few of those logistics. I'll remind you that if you're at home, the washroom is likely down your hallway, probably across from your bedroom. I'd like to tell you that refreshments are free. They're available freely this afternoon. You just have to get them from your own fridge. And Virtually Casper entertainment may be provided by my dog snoring in the background, and I will apologize in advance for that. I do have to tell you some details, though, sort of in terms of logistics. I want you to feel free to write your questions using the Q&A box at the bottom of your screen anytime during the session. So during the presentations, if you think of a question, just pop it in there. We'll do our best to ask as many as possible at the end. Because there are so many participants, we're going to ask you not to use the chat function to put your questions in. I'm the only person monitoring them, so I won't be able to keep up. So if you put them in the Q&A, that would be terrific. The chat will be turned off during presentations, and we will turn it back on when we're having our discussion and Q&A session. And of course, we know that everyone will be respectful in their communications, both in the Q&A and in the chat box. And I just want to remind everyone that the sessions are being recorded. So the logistics are done. Now to the heart of the session and what you're all here for. And before we get started, I'd just like to take a moment. Our discussion this morning, for any of you that were on it, Dr. Josh Tepper just reminded us of the importance of reflecting for a few minutes on the hundreds of thousands of lives that have been lost due to COVID-19 across the globe. The families that are grieving, the communities that are hurting, the people that have lost jobs, just a massive impact. And he just reminded us that we're all here for a reason, and that's to help out through this crisis and to learn from it, but that we shouldn't forget the humanity and we shouldn't forget the toll that this has taken on so many lives. Just like a couple of comments before we get started. For the last several months, we've all been immersed in the immediacy of the pandemic. We've seen in real time the magnitude of the many direct impacts of COVID-19 on our lives and on the healthcare system. And while the immediacy of the crisis has engulfed us, what we haven't yet grappled with are the downstream consequences, the collateral damage, if you will. Today, our panel are going to start that conversation as we discuss the gaps and inequities that have been revealed after the COVID-19 and beforehand as well, and the wide-ranging collateral damage of the pandemic. I'm really looking forward to the discussion. I'm looking forward to the questions that you have. I'm looking forward to the presentations. It's important for us to think about the far-reaching impacts of COVID-19 that are exacting such a largely unseen toll on individuals, communities, and society at large. We have a great panel here today, and we're going to start. I'm going to give you you can read their bios, but I'll just give you a very brief introduction to each of them. So Colleen Flood is well known to many of you. Her accomplishments are well known in the health services and policy research community. She's a thought leader who's focused her research on the role of law in shaping health and healthcare systems and the most appropriate role for the public and private sectors. Colleen is uniquely positioned to challenge our thinking today about the collateral damage that is emerging related to COVID-19. As well, we have Amélie Quinel-Vallée. Amelie's work is centered on understanding how policies contribute to social inequalities in health over the life course. She's also very highly regarded in her work relating to the most invisible work of millions of Canadians who are unpaid caregivers. We're honored to have her here with us today as well, and to help us to see the impacts of COVID-19 through a lens of social inequality. We also have Lisa Ridgway here, a patient partner. Anyone who's been at the sessions over the last day and a half will know how important patient partnership is and what a theme that's been during our sessions. Lisa is a fierce advocate, a support, and a source of knowledge for many in the patient advocacy community. She has a lot to share, and her lived experience combined with her relentless pursuit of patient and caregiver-inspired system design make her a much needed and welcome voice on this panel. And so with that, I'd like to turn it over to you, Colleen.
Share my Okay, can you see? There we go. All right, so we're off to the races, and thank you very much for your kind introduction, Maggie, and lovely to be on the panel with Amélie and Lisa, and I look forward to our discussion. So I'm kicking off talking about civil liberties, and just to start, I think that most of us probably find all the sweeping changes that have come about in the wake of COVID-19 quite overwhelming and almost difficult to keep in your mind at one time. And I think most of us, though, have understood the need for these measures to tame the curve, as they say, so that we have time for our hospitals to treat cases in an orderly way without being overwhelmed. And importantly, time to study the disease and develop treatments and hopefully a vaccine. But the measures taken to flatten the curve impose real collateral damage and other public health harms. We will, oops, I can't seem to move it on. Oh, here, voila, pardon. Some of these include the fact that lockdowns increase the chance of infection in overcrowded homes and settings. And I think we'll hear more about that from Amélie shortly. The impact of increasing amounts of unemployment and loss of income and the correlation between that and health outcomes. The very real delay of elective surgery or even denial in many people who have put off receiving necessary care. Folks who are unable to support the dying loved ones or those living in long-term care. Increased isolation and loneliness, increased risk of suicide. Many reports of increased domestic violence. And more globally, disruption of food supply chains coming about, for example, from border closures. And a recent study in The Lancet found that COVID-19's disruption of basic services in 118 low and middle income countries may in the next 6 months lead to an additional 1.2 million deaths of children under the age of 5. So these are very significant collateral damage that we, I think, will be accounting for and studying in the years to come. But I'm going to talk about a particular kind of collateral damage in the sense of civil liberties. And this idea of civil liberties, or the rights of civil liberties, are often pitted as in conflict with public health and measures that are taken to battle COVID-19. So hence my pugilists. And I'm going to make 3 points about civil liberties in the time of COVID-19 as follows. First, that civil rights and public health approaches are not in fact oppositional, they're not in fact pugilists in the ring. Second, that public health needs a healthy respect for civil liberties, and that in fact good public health policy requires it. And then finally, that public health officials need to understand that the evidentiary burden falls on them to show that they could not achieve their objectives with respect to COVID-19, not the other way around, not on the person trying to argue in favor of protecting their civil liberties. And I think that frame of reference is really important to understand where the evidentiary burden falls. So let me just give you some examples of civil liberties in peril. In some countries, COVID-19 has implicated the right to free expression. And as the disease was first discovered, you probably saw pictures of this doctor, Li Wenliang, who went public with his fears of a SARS-like outbreak early on, only to be detained by police and forced to recant in a public statement. He later, unfortunately, died of the disease. Closer to home, concerns about freedom of expression take a different form. One issue has been the proliferation on social media of misinformation and conspiracy theories about COVID-19. And this in turn has prompted some discussion of enacting laws to punish individuals responsible for spreading pandemic misinformation. Another civil liberty that has been jeopardized or overridden in the context of COVID-19 is freedom of assembly. And most provinces have set limits of varying degrees on public gatherings, which is a serious intrusion on the Charter of Rights and Freedoms, Section 2C, which protects freedom of peaceful assembly. And these restrictions are often backed by serious sanctions. Ontario's limit on gatherings of more than 5 people is punishable by a fine of up to $100,000 and up to 1 year's imprisonment. And imposition of these laws are variable, and this is another part of the problem, is the policing of these laws. For example, the Hamilton Spectator reports that the city's police force issued $750 fines to a group of 10 homeless people who were allegedly passing around a bottle of alcohol. In the city of Montreal, a group of homeless youth were ticketed $1,546 each for failing to obey physical distancing measures. And I should note that this variation across the country, I think, causes a lot of confusion, different rules at municipal, provincial, and from province to province. Another important civil liberty is the freedom of religion, which is linked to the freedom of assembly. And the pandemic response, and specifically these restrictions on public gatherings, impinges on the right to religion, which is guaranteed under Section 2A of the Charter. But both in Canada and the United States, we've seen flare-up of coronavirus from church services, and yet some of the most vocal protests to lift lockdown measures come from religious groups. And President Trump of the United States has drawn upon this pressure to galvanize his general push for a hasty reopening of the US economy. Another civil liberty is mobility rights. As we know, the federal government has limited travel into the country, closing off borders to all foreign nationals. Canadian nationals and permanent residents are permitted to re-enter, but are required to self-quarantine for up to 14 days, with various fines and imprisonment possible for non-compliance. And some provinces, moreover, have prohibited travellers from other provinces, so intra-provincial travel, with checkpoints at various entries. And all of this represents a considerable interference with civil liberties. Mobility rights engages people's ability to reunite with their families, to pursue a livelihood, and so on, and are all protected under Section 6 of the Charter of Rights and Freedoms. Privacy, obviously, many people talk about this in the context of civil liberties and the prospect that measures taken are threatening privacy rights. And I think, those of us reading about COVID-19, it seems 24/7, know that testing and contact tracing are the best tools we have in containing infectious disease outbreaks. And the provinces are beginning to experiment with cell phone applications that employ GPS and Bluetooth to trace the movement of infected individuals and warn those who've been exposed. And while these measures seem to have been employed effectively in some jurisdictions, for example, in South Korea, Canadian privacy experts worry that we might be crossing a Rubicon into uncharted territory in terms of state surveillance. And following the adage that, hard cases make bad law, they worry that the pandemic might simply soften us up, maybe you need to soften and serve, soften us up for other invasions of privacy. For example, to change a core tenet of privacy law, which is that commercial enterprises should not disclose personal information without express consent. Surveillance and privacy concerns are also arising from the use in some countries of drones. For example, here in Spain, Spanish police using drones to monitor people and help enforce lockdown measures. Okay, so those are some of the examples of civil liberties that are challenged in the context of COVID-19, obviously extreme variations from country to country. And we know, here you are, break the casing and get out your emergency pen, that when we are in normal times, and they seem so far long ago now, but governments have time to reflect on what they are doing. They have time to gather the evidence and to try to attenuate concerns about civil liberties, to balance that with their policy objectives. But in a fast-moving pandemic, governments are forced to make urgent policy maneuvers impacting civil liberties in a vortex of uncertainty. They don't have the luxury of prolonged deliberation. Very often, actions are taken pursuant to emergency legislation, using executive orders. And so this means there's not the protection of legislative debate as well. Okay. So as I sort of set it up, there's often viewed as this conflict between public health and civil liberties. And at first blush, they seem irreconcilable. So civil libertarians will argue that civil rights are so fundamental, for example, the right to religion, the right of freedom of association, that they cannot be overridden in pursuit of a public health objective, particularly when it's not necessarily even known if the measures taken will actually save lives. And yet, on the other hand, public health experts have traditionally relied on the precautionary principle. And that's the idea that governments should take precautions even when there's little evidence about the scale of the risk or the factors driving it, and that the burden of proof should be on those who want to abandon precautionary measures. So this is most famously put by Anthony Fauci, who says, if it looks like you're overreacting, you're probably doing the right thing. Okay, so my first point, though, is that there is, in fact, I think, less distance between civil rights and public health objectives than first meets the eye. And in the Canadian context, civil liberties are not trumps. There's not one ring to rule them all. And the limits on individual rights, on civil rights and liberties, are made explicit in Section 1 of the Charter of Rights and Freedoms, which states that charter rights are subject to such reasonable limits prescribed by law as can be demonstrably justified in a free and democratic society. So in a nutshell, as long as the government is reasonable and proportional, even if civil liberties are infringed, then this can be acceptable. But it's important, really important to note that the government can't rest on its laurels. It will be up to the government or public health officials to bring the evidence for its action, for the limits that are required on fundamental rights like privacy, religion, or freedom of association. So it's not a slam dunk for public health officials or governments to say, look, it's all for COVID-19, we're saving lives, sorry about your civil rights, too bad, how sad. That's not possible. And the test for Section 1 of the Charter of Rights and Freedoms, it's known as the Oakes test. It's a 4-part test, and it is quite demanding. And I'm not going to read it all out for you, but just to note that to achieve all of this requires a fair bit on the part of the government. For example, the question 3, is the right minimally impaired, means that the government must provide some evidence that it could not achieve its objective, for example, curbing COVID-19 without overriding one's charter right to religion, if there was no other reasonable option. If there was another reasonable option to do it with, which didn't require stopping people meeting to practice their religion, then the government should take that option. It is important to note that one size doesn't fit all here, and that courts will be or bring a different degree of scrutiny depending on the subject matter. So, for example, courts impose a heavier burden on governments in the context of criminal law, but they will be more differential to governments in matters that are polycentric or where action is being taken to protect vulnerable populations. And a wider latitude is usually given in response to national emergencies. So you see, because of all those factors, courts are likely to be quite differential to the choices that governments make, even if they're overriding civil liberties in the context of COVID-19, at least in the earlier part of the outbreak before the evidence amasses. So I've argued here that civil liberties is civil rights perspective is not an all or nothing affair, and that through the lens of the Charter, the courts will be they'll be respectful of reasonable choices by governments, even if they infringe upon civil liberties. And now I want to argue the other side, and that is that the public health perspective is quite receptive, I think, and increasingly so, to the concerns that are traditionally associated with civil rights. Okay, so the way that we normally understand, it was often portrayed, this idea of the precautionary principle, is that we should act, governments should act, even without full evidence before us, because if we don't, then the consequences could be horrific. Right, whether it's to the environment, whether it's to the health of the population. So we need to act even before we really know what we're doing sometimes. But this idea has been criticized for its one-sidedness precisely because it doesn't take account of the collateral damage. So it fails to acknowledge that the precautions themselves may have significant risks. For example, lockdown measures imposed as a precaution against COVID-19 may deter people seeking essential healthcare, trigger mental health issues, or cause dangerous disruptions to the food supply. We know for sure that it has caused an enormous economic shock and loss of jobs and income, and in the longer run, these two will all have impact on health. So in other words, there's a risk on both sides of the ledger, and wise public policy should interrogate all the risks and their probabilities. And to ignore the cost, the collateral damage, amounts to what behavioral economists call probability neglect. So I think the public health community, theorists and practitioners are increasingly alive to these considerations. And it's the application of the precautionary principle has evolved to incorporate a more balanced accounting of the risks and avoided and the risk created by the precautionary principle. So this is an example of this. And again, I'm not going to read all the lines on the screen, but this is guidance from the EU on the precautionary principle. And I just want you to note that the various features of this actually bear a lot of resemblance to Section 1, the Oakes test of the Charter. So that's interesting, right? So the evolution of the precautionary principle actually looks a lot like what the courts ask of governments in a Section 1 analysis. So you see the emphasis here on proportionality and cost-benefit analysis, and that the requirements of consistency with measures already taken, which echoes the minimal impairment stage of Oaks. Okay, so this is where the kid comes in and booms you. Hi, Connor. All right, so let me conclude with some final observations.
It's my birthday.
It is his birthday tomorrow, folks. So, okay, can you go now, darling, so I can finish? Good boy. So first, that there's more in common between a charter rights analysis and the practice of the precautionary principle in public health than at first meets the eye. So they're not in opposition, a straight opposition. There is more of a relationship between them. Second, that both a proportionality analysis and the precautionary principle both require that governments not rest on their laurels. By that I mean that as new evidence comes in, if it is possible for governments to achieve their objectives of curbing or eradicating COVID-19 without infringing civil liberties, if there is a reasonable alternative, they need to take that reasonable alternative. Finally, that public health officials need to understand that the burden of proof will be upon them in a charter case under a Section 1 analysis to explain why they need to override or infringe upon someone's civil liberties in the context of a charter analysis. And I think this sort of understanding of who the burden of proof really lies with is a super important one for folks in practicing public health to understand. And finally, though, I would say that civil libertarians, on the other hand, must acknowledge that freedom from governmental constraints can be a wee bit overrated if you're dead. And by that I mean, you know, interpretation and protection of civil liberties should not come at the expense of human health, so that in the end result, we're not, as I say, dying with your rights on. Okay, so that's my wee stab at, I don't know if that's the right metaphor, but my wee stab at civil liberties, and I look forward to your Q&A, and I really look forward to hearing Amelie and Lisa. Thank you, Maggie.
Thank you so much, Colleen. We should sing happy birthday to your son.
Perhaps not.
Thank you so much. That's a lot to think about, and I think there's going to be some interesting discussion when we're done. Amelie, I'd like to turn it over to you and hear what you have to say as well.
Thank you. And Colleen, I have to say, you know, BBC Dad has nothing on you. You just managed that with such beautiful aplomb and poise. Yes, there we go. So thank you very much for having me. I'm really delighted to be able to talk to you today about the social determinants of health and how they have played out and are going to play out even further with COVID-19. Essentially, this, I think the title says it all, physical distancing is a privilege. We need to recognize it. And, you know, on the heels of the admonitions that Colleen put forth for us to think about is also this issue of the inequalities. And I think it's been clear in many jurisdictions that the public health authorities have heard this message loud and clear, fortunately, and that they are very much concerned about what is going on along the lines, the social fault lines of social inequalities. But this is something that is very much it's a concern for us all throughout society, and certainly when we study health services and policy research as we do at Casper. So the basic message is COVID-19, as many other diseases before it, has been exploiting social fault lines, and it will be exacerbating those social inequalities and those social gaps in a way that has up until now never been seen in terms of the scale and the speed. And I'm going to give you some examples that are taken from what's going on in Montreal and elsewhere to illustrate that. Before I get started, given that our sponsor is the CIHR Institute for Health Services and Policy Research, I just want to put it out there that I am a member of CIHR Governing Council. I have no conflicts of interest otherwise, and I'm I'm fairly certain that I wasn't invited to this session because of that position on the CIHR Governing Council, and I'm not receiving funding for speaking today. So what makes Canadians sick? Here I'm bringing this, this concept of the social determinants of health. As you well know, Casper's bread and butter is healthcare, and this is what we see here in the turquoise. So according to, and this is a graph, an infographic from the Canadian Medical Association, so coming from the horse's mouth as it were, that only, you can say only or as much as 25% of one's health or one's population health is really coming from healthcare, whereas a full 50% or even perhaps more if we take in the environment of our health is actually coming from what they call your life and what we would call social determinants of health, ranging from early childhood development all the way to community belongingness and the social safety net. So those big broad policies that have an impact on our life. So this is to say those determinants that are in the red are extremely far-ranging. They are interrelated and they interact with other factors such as healthcare, access to healthcare, biology, and the environment. And nowhere has this been more evident than with COVID-19. Another concept that I want to bring forward is this idea of the fundamental determinants of health. So Lincoln Phelan in 1995 had a thinking piece about why it is that through time, through societies, we see social determinants of health come to the fore as being important. And while the disease, the major killers are changing over time and the shape of those inequalities is changing over time, we actually see the social determinants emerge and reemerge time and time again. And here I'm going to give you an illustration that will set the stage for showing how quickly COVID-19 has emerged as a social fault line relative to other major determinants, social determinants of health. So these are data that we see from the UK. This is premature mortality among men, and in 1949 to 1953, and you see this RGSC is the Registrar General Social Class. So one of the advantages of the UK data at the census is that they have collected the social position of individuals for a number of years. In here you'll see from 1949. So we have very long-ranging data. In this categorization, 1 is better and 1 is higher social status and 5 is a lower social status. So 1 would be the, for instance, lawyers and professionals, and 5 would be the more laborers. They're the unskilled manual social classes. At the time, and the way to interpret this, these are SMRs, standardized mortality ratios. 100 is the population average, more than 100 is worse outcome, and less than 100 is better outcome than the population average. So what you see from these data is that in the 1940s, so the end of the 1940s, 1950s, we actually had a gradient that was so-called diseases of affluence. So actually coronary disease and diabetes were more common. You see that the numbers here for the more privileged social classes are higher. So they're above 100, meaning that those classes were more likely to die prematurely of those conditions. Especially here of those individuals relative to those individuals who are in lower social classes. The contrast is evident with TB. So this is the more classic social gradient that we're used to seeing, where those individuals in the higher social tuberculosis here are dying less than those individuals who are in the higher social class, in the lower social classes, where they're dying more. So this is just a portrait of what we tend to take for granted now in terms of social gradients. That was not the case in the 1940s. And what we can explain that fairly well, as I said, diseases of affluence. So individuals in the upper social classes had more plentiful nutrition, They were also more sedentary than those individuals in the lower social classes. But more importantly, the knowledge and the treatments were not as effective at the time. And so those individuals in the higher social classes were not as able to take advantage of those resources, that is information, and the way to protect yourself from disease, as those individuals in the lower social classes. Now, the changes just 50 or barely 40 years later, in the 1990s. And what you see now is that all the diseases that we're showing here have the so-called social gradient in health, where those individuals in the higher social classes are much less likely to die prematurely from those causes than those individuals in the lower social classes. And note that here in cancer, we had barely any gradient. There was no discernible gradient, but by the 1990s, there is a discernible gradient. And this is because of the increases in access to diagnosis and the efficacy of treatment as well. In further information that I should reiterate is that this is the UK, this is the NHS. So there are technically no differences of access to healthcare here. And so this is, I think, a very, very clear example of how diseases, so-called diseases of affluence that are in the 1950s that were affecting the upper social classes more than the lower social classes, can switch over in a matter of 50 years to becoming the so-called diseases that are affected by the social determinants of health that are showing this inverse gradient in health. 50 years. 50 years of information, 50 years of research, 50 years of access to better data. COVID-19 is doing that in Montreal, at least, in a matter of weeks. And I'm going to show you a little bit of data pertaining to that. And if I can move. I was fighting against the Zoom here. So these are maps that a colleague, Jay Brophy, put together and published on Twitter, showing that in Montreal, the early onset of the epidemic started in those more central neighborhoods, which happen to also be neighborhoods that are of higher socioeconomic status. When you run the epidemic for, I think this was 6 weeks later, 6 to 8 weeks later, and you see that now it has the epidemic in the darker color, so this is where you have more cases, has run into the outlying areas, especially those northern ones, and a little bit here, so these are poorer areas, so it has moved outward into those areas. And this was also, as you'll see, this was actually post-lockdown. So there are interesting dynamics at play here. So the way it played out, the way COVID-19 played out in Montreal was from a disease of affluence at first to a disease of deprivation. So the story starts in Outremont, but also in other similarly high-income neighborhoods, and also low-density neighborhoods, and that becomes important later on in the epidemic. And the story is one of travel. So you may have read about the fact that Montreal is at the center of the epidemic, so we're sadly famous for that right now. And part of the reason, there are many, of course, reasons, but one of the reasons has been bad luck. We had our spring break as one of the earliest spring breaks. Quebecers, not surprisingly, want to go to somewhere warmer, and it's not very difficult to do, but that also tends to often involve travel to Europe. And so there were many travelers who came back around March 7, March 8, and the pandemic was not declared until March 12. And so we had a very good and some of the early lockdowns, so the closing of schools didn't happen until March 13. Montreal is one of the most, the city that uses public transit the most. And so you just have what we know now when we look at the modeling, a good 5 to 7 days of potential asymptomatic community transmission. And that set the stage for the later stages of the epidemic. Of course, the long-term care facilities are another angle that I'll get to. But just note the shape of this epidemic here, or the shape of the transmission, the cases in Outremont, so this high-income, low-density neighborhood. You see that this is all post-lockdown. So we have the surge of cases. Most of them are in blue, the dark blue. So this is in the milieu ouvert ou inconnu, meaning that it's open, it's in the community. It's not in a facility, which is the light blue, and it's not a health worker. You see a couple of health workers in orange coming up in the later stages. Those were plausibly individuals who were probably most likely physicians who were working in certain facilities. There was a lot of spread in many hospitals as well as long-term care facilities. Now, so you see, keep in mind this, like to the left, essentially the epidemic is concentrated to the left. Post-lockdown, there really is then a flattening of the curve in that neighborhood. And now take a look at this. So this is Montréal Nord, low income, high density, very, very high density, one of the densest neighborhoods in Montreal, in North America, sorry. And here you see post, 14 days post back to the 14 days after the return from the spring break, there are essentially no cases, and then it picks up. And note the orange. So these are a lot of blue. So the light blue could be attributed to long-term care facilities. These are so-called closed environments or institutional environments. But it's the orange that is really the striking feature here. Again, low income. And so these are not doctors. These are personal care workers. These are individuals who were working in long-term care facilities who had very low access to a PPE, to personal protective equipment. They're mostly women. They're mostly of ethnic minorities, racialized minorities. And they came back to dwellings where isolation is not an option. They went to work in places where they have to go to work in order to make a living. They often work several long-term care facilities. So this is part of the spread that we were talking about, and you see it in a very stark way, ripping through this population and taking advantage. So here again, we're talking, look at the scale. What I showed you for diabetes, and by the way, diabetes is also one of the players in this game of COVID-19, and is probably playing a part in this epidemic here. And also in the spread of this epidemic. And so this is not something that is unique to Montreal. It is not unique to Canada. This has been this difference. So I mentioned that this Montréal Nord is also a very highly racialized neighborhood. And so this is where we see that COVID is shining an extremely bright light on the social fog lines that were pre-existing COVID-19. And it's exacerbating those differences. In the US, it has also meant, and in the UK as well, so you see here CNN and The Guardian. So this has been true in both of those locations. We do not have access to the data in Montreal and in many other jurisdictions, although Toronto and other jurisdictions in Ontario have started collecting data on racialized minorities as well as on income to be able to monitor these, the excess death among those populations. And this is something that would be sorely needed in our context as well, is being considered by public health. But there are some considerations that are being named of risk of stigmatization, so we can discuss that. And as you see here in policy options, this has been mentioned as a concern in Canada as well. Other fault lines that we need to bear in mind as COVID-19 is exposing these gaps is the impact on the work hours. That graph to me is staggering. So you see here moving from lower income, so lower wage per hour, lower hourly wage to higher hourly wage. The amount of disaster that has happened in those various groups and the way that it is socially patterned. So here we have a very large loss. The loss of job is really occurring at the lowest levels of income, as well as the number of lost hours, although that is more evenly distributed. But the lost jobs, the consequence of that is that those individuals, as we are now facing the lifting of lockdowns, those individuals who have lost their jobs will find themselves in very vulnerable positions to potentially, as the relief funding dwindles down, they might find themselves in a position to take a job, any job, and put themselves at greater risk, themselves and their families, with the higher risk that they're living in highly densely populated areas. The other dimension that has been exacted in COVID-19 epidemic is that of gender differences. In Canada, we are facing a particular situation that in contrast to other places in the world, women actually make more, represent a greater proportion of the deaths in Canada. This is likely very much related to the fact that the epidemic has been highly concentrated in long-term care facilities and that women live longer than men, but absolutely something that needs investigation beyond that initial intuition. In addition, there are the social factors that are associated with COVID-19. So the lockdowns, the school closings, we know that we have gone back in terms of gender division of labor, even among the most educated households. And so, for instance, the Guardian has titled that the pink collar recession, and how it could set back a generation of women. So it will be very important going forward that the support for women who want to be able to go back to work be there. And finally, so the federal government is paying attention to that, and notably along the lines of considering recognizing that women have not only been most affected by those job losses, but they have also been heavily affected as being at the front lines of providing care for being essential services, but also in healthcare, as I mentioned, was the case in Montreal. So in closing then, I have hoped here to highlight that we need to not only focus on the biological risk factors for COVID-19, so age and pre-existing conditions, which are absolutely real, but that also they cluster these pre-existing conditions, notably diabetes and high blood pressure, overweight and obesity, cluster with social determinants, and to not focus on those social determinants, to measure them and to also put them out as risk factors may obscure the role of the fundamental social causes of disease, and which are obviously at play and in a very, very rapid way. So we need to collect better data on those social fault lines. It should be an imperative, and some jurisdictions are doing it and need to be modeled. We need to model our actions on that. But obviously always, and thinking about some of the considerations that Colleen has highlighted, we need to be careful about stigmatization. I was particularly personally concerned about policing associated with some of those the epidemic moving in different neighborhoods, and so far we have seen that this has been done. The move to support to stem the spread of the epidemic in those neighborhoods has been done in a very, very careful manner, supported by the public health authorities that have worked in concert with the community organizations. So far, so good, but we can't let our guard down, and it doesn't mean that in other communities also this is something that needs to be really taken into consideration. So I'll stop on that, and I look forward to our comments and discussions and to Lisa's wrapping up comments.
Great. Thank you very much, Amelie. I'll just remind people that as you have questions, please put them in the Q&A. We've been monitoring them, and there's some really good questions, so it's going to be really interesting to have a conversation afterwards. Lisa, I'd like to turn it over to you, and looking forward to what you have to say today.
Thanks very much, Maggie, and thank you to Casper for opening up the virtual doors to patient partners everywhere, and especially warm welcome to me as the patient partner on the panel of this very nimble and quick adaptation to virtually Casper. I'm calling in from British Columbia, and I do want to acknowledge and share the privilege we hold here in BC because we live on the unceded territory of Indigenous peoples across our province. And BC is home to almost 200 distinct First Nations and Métis chartered communities, and thank you for that privilege. Now, I did tell Maggie I was going to start off with a little bit of a question directly to Casper, and that is, Casper and the board of directors, why isn't there a patient partner category within your organization so that patient partners can join? I'll just leave that out there for a discussion. I do want to utilize the brain trust that is here, and I want to acknowledge and thank the fact that everyone has let me into their homes, but this is not one person's time. This is time for all of us across Canada, and especially for the patient partners who have joined us, and especially during the questions and answers. I am a patient partner, and a patient partner is a person who shares her lived experience through healthcare research, among other things. Casper and Maggie have described Emily and Colleen as legends, and wow, I'm not a legend, maybe in my dog's mind, but I'm not even sure really about that. But no patient partner gets here right now by herself. She is helped up and held up by others. And like I was, by two really strong patient partners, Beverly Pomeroy, my co-host of Sporecast, the POR podcast, and Carolyn Canfield, who is so good at synthesizing the patient voice that UBC made her a professor. Well, both are stewards and leaders of patient engagement, but there are other people too from within my own health authority. Cindy Triton, who's the Director of Research and Capacity Building. From within the BC Support Unit, Taylor Hainstock, and from its parent organization, the BC Academic Health Science Network, Dr. Sterling Bryan. I didn't get here alone, but these are my thoughts alone. I'm not speaking for the BC Support Unit or Casper or the BC AHSN. I'm speaking for me as a patient partner and a patient partner in health research. I'm not a family advisor. I'm not happily, thank God, a bereft relative. I don't have COVID-19, and I'm not a caregiver. But I have seen systems and institutions suffer in the last 2 months. Patient partners, like Zaina said earlier this morning, had come a long way. But now, I think neglect and maybe even willful blindness have seemed to define the role of patient partners. The systems and the institutions I'm going to talk about, they have a fiduciary duty to patient partners, and some have done very well in upholding that duty, but others have breached it. Now, my lived experience is with mental health, and it's not a secret, and nor will it ever be, that I had treatment-resistant depression for years and spent 9.5 months in a psychiatric program at the Royal Jubilee Hospital. But I'm okay now. I'm okay to be in front of all you people today, and I'm really lucky to have had a champion psychiatrist, Dr. Wei Song. The mental health pandemic is coming here, and it hasn't in any way shown itself. That's really what scares me most. Maybe COVID-19 will help with the stigma of mental illness, and that's a silver lining, but boy, it comes at a heck of a cost. Anyways, I'm not here to genuflect at the altar of lived experience. That's not how policy decisions are made, but A bit more on that later. I'm not a patient partner in name only. I've brought grants to teams at UVic and UBC. I do research on those grants. I work with students, clinicians, and project managers at UBC and UVic, and there's no better feeling than being a patient partner involved in healthcare research or within your healthcare system. Now, recently I was hired as a patient partner in the Department of Psychiatry led by Dr. Fidel Villa Rodriguez. I'm proud of that. What a good unintended consequence of the pandemic. Now, in law firms, there are people known as full equity partners, and there are non-equity partners. And let me tell you this, I am a full equity partner in healthcare research. Equity has a very different meaning in health research than it does in the law firm. It doesn't mean holding the financial reins. It means promoting everyone within the research life cycle, within healthcare, to have an equal voice, no matter your gender, your age, your race, your social class. Now, I'm a patient partner under a national initiative and a coalition of partners called the Strategy for Patient-Oriented Research, which is delivered under CIHR and is funded by your tax dollars. It's a strategy. It's not one of the virtual institutes. And, you know, patient-oriented research, it hasn't been around for all that long, or at least it hasn't had that sort of title. One of my closest cadre of patient partners remembers it starting right in the early part, around 2000, so 20 years. And SPORE, the initiative, has been around for about 5 years. Now, every support unit, all 11 of them, are now making submissions to the CIHR to renew their funding. It's worth about $30 million here in British Columbia. I'm the patient partner co-applicant on that grant. And at the BC support unit, they have welcomed the patient voice as a full equity partner. Now, from this national platform, I'm going to give a shout out to many, and I'm going to call out a few. This is not the time nor the platform to take small steps, because I think personally, there's a chasm opening up in front of us in healthcare and in healthcare research, and you don't cross a chasm in small steps. But let's just step back from the brink for a moment and sit down with me in your mind. I play the piano, and I want you to think about a piano keyboard, because I don't know if any of you play the piano, but there's no such thing as one note. Each note is played with the other, like an arpeggio, where you bring basic blocks of notes together, which build scales, which build music. So we can't really talk about the patient experience, because that's really self-isolating. That's just one note. There's a healthcare experience, and that has nurses and frontline workers and families and caregivers and patients, clinicians, cleaners, volunteers, and those in the corner suite. So when you play scales, you play arpeggios, you use them as building blocks, and that's where each of our voices is. And when you can't hear one, like the patient partner voice, the healthcare system is not working. I have felt the unintended consequences of the pandemic at 4 different contour lines, or think of them as isobars, because we're like a weather system, we're always under pressure. The first contour has been my personal experience, and telepsychiatry has worked really well. I have a really good, long-term, outstanding relationship with a caring doctor. We trust one another. Would a phone call have been enough if I was in the agony of treatment-resistant depression? Please, let's move to the virtual model as soon as we can. There are people dying out there, and some people are taking their own lives. So personally, I helped flatten the curve, like I think most of you did out there, by staying home and tending to the absolute every need of my now very overweight 70-pound Labrador. The second contour or isobar is that on a regional level, there have been trade-offs, because these are terrible times, and some things I don't understand. It didn't take me long to figure out that my voice as a patient partner was missing at the regional level. I am really privileged, truly privileged to live in the Island Health Authority and humbled by their efforts, especially the CEO, Kathy McNeil, and the emergency response efforts of Island Health. A few weeks ago, I was grumpy, a grouchy woman, and I sent out an email and I called out the complete shutout of patient partners and volunteers from the Island Health system in full knowledge that what they were doing was to keep us safe. But I called out what I thought was wrong and championed by Cindy Triton. I think I crashed the corner suite. And now in a few short weeks, there's a patient partner committee emerging from that pendulum swing of total deployment of the patient experience to the emergency roster back to patient experience. And that's not to my credit. That's to the credit of Island Health. Maybe like Xenia said today, I just undid some inertia. But let me tell you, there isn't another place that I would rather be right now. Kathy said to me, Island Health had to start off with a blunt instrument to tackle COVID-19. They had to. And in my mind, that was their fiduciary duty to patients. And it worked. But to me, they started to store up more than PPE. They stored up problems that are only surfacing now. But they're listening. And now we're pushing frontiers across Canada with a new visitor policy. Island Health is modeling patient engagement. They're opening it up again in a virtual way, but that's the safest way now. And for its CEO, Kathy McNeil, she's been humble and shown courage. And I want to say thank you. Now, the third contour or isobar is the provincial level, and no speaker from British Columbia at a COVID-19 conference can help but mention Dr. Bonnie Henry. But I also want to mention another person in government, and that's John Horgan, because he gave her the lead, and that's leadership. And look at her go. Now, I want right now to talk about a special research advisory committee formed in our province called SRAC, which was created as a bridge between the provincial health officer and the health research community in British Columbia. You know, I was going to write an open letter about this, but it's much better to say this in front of a lot of people. You cannot have a committee that purports to represent health research during COVID-19 without a patient partner. It is fractally wrong. You have lawyers, professional engineers, pharmacists, communication experts, registered nurses sitting on provincial patient councils across British Columbia. Why wouldn't you use us? Please direct message me on Twitter. Let's talk about this, because, you know, to me, your no is only the beginning of the negotiation. And I know this has happened in other provinces across Canada. And you know how I know? Because I talk to patient partners, and I've had cross-country checkups with Bev Pomeroy with them every couple of weeks. And we are not isolated, and we listen to one another, and we wonder, where have the listening skills gone? There's a lot of noise. I participated in focus groups for SRAC, but the chasm is so deep, a group of good people with good intentions on both sides. Do I have to build the bridge as I walk on it to you? If you want cooperation for patient and public safety, but not the corollary of patient experience at a high level informing the research that we are doing to support Canada's rapid response to the healthcare challenges of COVID-19. You know, we are a value add. Lived experience is a value add, plus so much more, including our occupational skills, our knowledge. We span divides. We are intuitive. There's a wonderful article in the British Medical Journal all about that. So please, SRAC, come and meet me, meet us as patient partners at the governance level. Now, nationally, some institutions have been champions. The Institute of Health Services and Policy Research, Rick Glazier and his mighty team have reached out through their advisory group and through their collaborative and established relationships with patient partners. And like Joshua said this morning, you know what he did? He just asked. He asked. That's what Rick and his good team did. He asked, did we make mistakes? How do we carry on? How do we correct them in COVID-19 with patient partners? How are we going to design this for patient partners? Now, nationally, I do peer review, and I am really busy with CIHR peer review for COVID-19. And last weekend, I reviewed 50 and more applications for conflict of interest, and some were so breathtakingly good, it made me cry, I kid you not. And some, they didn't mention patient partners, they didn't mention lived experience, and that makes me want to cry too. You know, putting patient partners on your research, it really does, and it can in some ways slow down the process. And there will probably be new budget lines about compensation, but research results build policy. And that's the translational side of our work at the outset. And policy is only built, good policy is only built on good evidence. So what do I do when I hear things like, oh, sorry, we didn't have time to recruit patient partners, or sorry, we didn't have time to send you the recommendations from the focus group, both of which those quotes I've heard in the last couple of days. That's not bad time management. I think that's tokenism, and that's a conscious decision not to make room. Now, yesterday, Sasha mentioned the cost of contact, and I'm going to say there's a cost of no contact as well, especially with patient partners. At the beginning of the pandemic, you might have got a pass for unintended consequences, but you don't get that pass now. Now, my last question on the national level is this: where is the patient-oriented call for patient-oriented research during COVID-19? That's the big one. Now, if I've missed it, you know, I'm sorry, I take full responsibility for my speech. It must be happening somewhere. Now is the time. What I'm really heartened to see is that the spring project grants are coming back up, because I'm a patient partner and there are lots of patient partners involved in those, and they are going to start to be reviewed this summer. So I'm at the top of those contour lines now, the top of those isobars, and I don't think I'm demanding the impossible. Patient partners and patients engaged in healthcare generally are a human resource. Ask them for help. Use them for their lived experience and the different voice they bring to their experience and to their professional lives. Use them to build cords. You know, my hope, my one hope for COVID-19, for our healthcare system, it comes from people. It doesn't actually come from institutions. And my people are patient partners. So Donna in Bedford, and Mike in Newfoundland, and Marianne in Montreal, Annette in Toronto, Sandra in Alberta, Heather in Saskatchewan, Claire and Yana in Vancouver, Gwen and Rita on the Provincial Patient Council of the BC Support Unit, and all my patient partners. Here's the open door. Please help me claim this space, and let's plant the flag for patient partners across our country. Now, I've had the privilege to be here and to speak for my patient partners, and now I'm going to indulge myself with the question and answer period, but I'm also going to watch, as are we all, because we are the witnesses to the experience during the pandemic. And next year, I'm going to watch with particular pride as one of my patient partners takes this position right here. Thank you.
Thank you so much, Lisa. Thank you to all our panel members. So much to think about. You've brought so much insight for all of us, so many great questions, and so I don't want to waste any time. I want to get right to them. But thank you so much. I'm going to start with a question. It's probably one that each of you should give your view on. And it's really about how can we better study unintended consequences or collateral damage so that we can include them in decision making. Can we start with you, Colleen?
Sure. How can we better study? I think that governments are aware of collateral damage that comes in the form of economic impacts. I think they're quite well aware of collateral damage, for ordinary Canadians, if you like, in terms of access to healthcare and trying to get that back on track. I think where it falls down considerably is for people that don't fit in the boxes. So for vulnerable populations who get the rough end of the pineapple, as I like to say, on many things. So I think that we have to really focus our lens, our research lens, on those populations and truly surface what the costs and consequences have been of various measures that, are fine for me in my beautiful house with my lovely backyard and my sort of perfect family and smelly dog. But for many people, that's just really untenable. So I think that's where we should really focus our research, in my view, and make sure that these for the costs and consequences for marginalized populations, for vulnerable populations, for the homeless, for people living in prisons, for Indigenous populations, for people in long-term care facilities, that these are surfaced.
Thank you. Lisa, what's your thinking beyond this?
Well, I don't want to repeat myself ad nauseum, but I think, how do you identify unintended consequences? You ask people that have the biggest stake in the healthcare system, which is patients. You get out there and you talk to the chronic disease network. You don't just concentrate on the upper levels, the CDC levels, those things. You get right down into the patient-specific groups. The ones who live with the disease and the ones who are suffering, I think, the most because of the unintended consequences, like Colleen said, Indigenous peoples, poorer peoples that don't have a roof over their head. Ask patient partners. We've got established networks out there. There are plenty of champions and advocates. All you have to do is ask. Thanks.
I would say that, I would go one step further than Lisa and say we need to bring the people in. They may not be patients yet, but we have theories, and the fundamental cause of disease is out. It was out there in 1995, and before that in intuition, certainly, and it laid it all out for us. But somehow we were still caught unawares. And so it's on us, really. And many of us have been out in the front lines of Twitter or whatever to say this is happening, and others from the communities have been saying this is happening, and marching the drumbeat of pay attention to this. But so that's one thing. We have the theories. We know where to look. These fault lines are going to be playing out. I think where we were caught is how fast it happened, and that's a it's just a, I guess, tribute or testament to this virus and the strength of the social determinants of health, that they will play out, and what used to take decades, as with diabetes and those diseases of affluence, now is taking weeks. So once bitten, twice shy. We have to now, we know it. So there is no reason that we can't look at the places. We know where it's going to happen. You know, meat packing plants, those lower income essential workers, that's where it's going to come from. And so we need to be really mindful of that. And then the second point is, and that this has been, I've looked at the question and answers, and the questions or points that have been made, data. It's no longer sufficient in this day and age in the 21st century to say we have data by neighborhood. That's no longer enough in terms of granularity, and also in terms of the real-time nature of the data. We are so far behind in Canada relative to other countries, and as far as that's concerned, and that is impeding everybody's action, the government and also our research. But first, government action.
Great, thanks, Emily. Colleen, there was an interesting question to you, and I know that you answered it online, but I think it would be worthwhile revisiting it. And that was around the mechanisms that we should consider to better grasp what civil liberties citizens and other groups are willing to give up, at least temporarily, in order to help governments and public health authorities.
Sure, and my response was that I think that's an interesting question, and how we engage with people to find out what they are willing to give up. But my response was that it's not majority rule, and I think that's a really important aspect to all of this discussion. What works for the majority is not necessarily going to work for marginalized populations. And from a legal perspective, this is exactly why we have a Charter of Rights and Freedoms, so that it's not majority rule. So if it suits the majority to have physical isolation in your own home or etc., that doesn't mean that an individual can't bring a charter rights claim to say, but for me, this doesn't work. Right? It may be that they won't win because, as I said, rights aren't trump. They have to be balanced with other considerations. But the argument that most of us are happy enough with the measures, well, that's good from a policy perspective, but it is not the solution from a legal perspective. I hope that makes sense.
Good. Thank you very much. Lisa, I have a question for you. There were several along this line, but I'll try and summarize it around the role that patients play in bringing research into action. Can you comment on how this can work during the time of COVID-19?
Sure, Maggie, thanks very much. Research into action, I think, also known as knowledge mobilization or knowledge translation. Well, here's a good example right here, bringing research right to the fore of this discussion. Another example would be through a podcast, for instance, bringing research results right across everyone's capabilities technologically. So if I'm sitting in a cafe somewhere at a social distance from somebody, I can tune into a podcast, or without sitting down around a table, I can join a virtual group. Zoom has been an incredible equalizer for patient partners during this time. We're all here at the same table. No one is taller. No one is sitting at the head of the table. We're all around it. So I would say using Zoom to bring research results to patients, even perhaps going as far as government or health authorities bringing tablets to people so they have internet connections, budgeting for those sorts of things. So there's lots of ways, podcasts, Zooms, technological openings for research results to get translated or mobilized to people during the pandemic. Thanks.
Thanks very much, Lisa. So we just have a few minutes left. I want to let everyone know that has asked a question that we haven't answered, that we will try and get back to people by email. There are lots of them here. Some are similar, but we'll make sure that we do that. I wanted to invite each of you just to, give some final thoughts. What your thoughts around what we can do as communities and as individual Canadians to try and address some of these social fault lines that we've identified today, how we avoid stigmatization, and just sort of how we move forward. If you could just give us some final thoughts, that would be really much appreciated. Colleen, I'll start with you.
I think, that in the midst of this pandemic, we are all spurred to rethink existing norms or existing ways of doing things. And what I hope is that this is not temporary. So I hope that at the end of COVID-19, that we just don't reset ourselves again back to, well, now it's over, it's back to normal, and it disappears in our minds as something important, and we go back to running around like crazy chickens with our head cut off, and not really thinking about the impact on people that are living without homes, that live in long-term care facilities, that live in poverty. I think that our failings as a society and a system have just been so laid bare by COVID-19. It's all on display, all the dark side. And as time goes by, we might want to just pat that over with as I do, throw the duvet over the mess, and bang the door shut. But I think we need to actually strip back that duvet and have a good look, and make sure that we really learn from this and fix things, and really start to govern and not give up on governance. For me, I feel like so often it's not possible because of arguments about federal provincial division of powers. It's not possible because of politics. It's not possible because of all these things. I think that's all malarkey. All of this is possible. So I hope that it's a spur for change.
Thank you. It reminds me a little bit about the report after the SARS epidemic. Before I was rereading it last week, thinking all the lessons learned there, many of them should have informed what the situation we're in now. So that's a really good point. Thank you. Lisa, do you have any last thoughts you'd like to leave our attendees with?
Sure. Thanks, Maggie. And Emily, I'll be quick because I'd like to hear your thoughts as well. Jennifer yesterday talked about old ways perhaps not working. But, in some ways, old ways are working because old ways are relational. And you build relationships with people, you network and you find champions, you find friends, you find people that think the same way you do, hopefully with the same goals. And so I think that's an old way, and I think that will continue to work if we can do this together. It's not for one person to solve alone, it's not for one champion, but it's for all of us to put our heads together and think. So yeah, let's just keep on keeping in touch with one another and build those relationships that will hopefully lead us out of the pandemic. Thanks very much, Maggie.
Thank you. Amelie.
Yes, well, I think I'll pick up one of the questions about whether I'm optimistic that the crisis will result in policies that will change, reduce, and help reduce some inequalities. So I'm just going to speak about Quebec, although there are some policies in the federal level as well. I will say that we're at this point, both at the federal level and in Quebec, we're getting really very close to a minimum income guarantee. Right? There have been checks cut out. People are being supported across the board. Although we've been told by our Prime Minister that this won't last forever. I mean, it's anybody's guess as to what the future will look like. And so I think this is already one of the ways that it was impossible, it could never be done, has been upended. And so there's a good, never let a good crisis go to waste. There's an opportunity there, I think. And it's also made it very clear that we're all in this together. And I was just listening to a podcast last week from the BBC, The Inquiry, how are we going to pay for COVID-19? We, like the world. And essentially they end by saying, maybe we won't. And so there may be in the sense that this has been so far-ranging for everybody, every country. Quebec is still talking, there is no mention of austerity. The word on the street is spend, spend, spend. And so what will that look like 2 years, 5 years from now? That may be a wholly different world that will continue indeed to be one where we continue to think about these social determinants, and they have been laid bare by the conditions in the long-term care facilities in horrific ways for everybody to see. And now people are aware across the board that this is a reality. Until then, we could kind of shield our eyes and look elsewhere. And so I think this is not going to leave anybody's consciousness, I hope, anytime soon. And so some of the gains will be very difficult to roll back. And so, of course, economist friends are going to say, what about inflation? And we'll discuss that in the next panel next year, maybe.
Thank you. So I want to thank each of you. So you have brought so many great insights, wonderful things for us to think about, to challenge our thinking. And I thank you for sharing your time and your wisdom. I really do appreciate it. And I know our attendees do. I'd also like to thank the sponsors for the session, so CIHR's Institute of Health Services and Policy Research. And I want to thank our attendees for your questions, for your interest, for your engagement. We will try to get back to you with answers. And I just want to remind you, this is our first foray into a virtual conference. We pulled it together really quickly, so we were going to be looking for your feedback. Our hope is that we bring more of these to our members. We think that there's a lot of opportunity to bring members some extraordinary content and some extraordinary opportunity. So if you're not a member, I encourage you to become one. If you are one and haven't renewed, I encourage you to do that. And I also just want to wish you well for this evening. If you are attending the next session, it's at 5 p.m. Eastern Time. Dr. Stephen Lewis will be, I'm sure, giving us things to think about. So if you're registered for that, join us then. If not, I wish you well. I wish you all safety and a good evening. Thank you so much for joining us today. Bye-bye.